Good morning, everyone, and welcome to the Antimicrobial Stewardship in Nursing Homes webinar. This is the first in our series of 6 webinars on this topic. This is Deborah Curdy, QAF Executive Director. We're pleased to be working with the CDPH and CAF on this webinar series. Please check the CAF QAF calendar as well as our websites for upcoming dates, and please note the next webinar will be on May 18th. If you have any questions during the presentation, please feel free to type in your questions using the question panel on the right side of your GoToWebinar player. Now let's get to this morning's program. I would like to welcome our 2 speakers for today's webinar, Dr. Erin Epson from the CDPH and Dr. Namali Stone from the CDC. Our first speaker this morning will be Dr. Epson. Dr. Erin Epson is Public Health Medical Officer and Assistant Chief of the California Department of Health Healthcare Associated Infections Program. She is board certified infectious disease physician who completed medical epidemiology training as an epidemic intelligence services officer with the Centers for Disease Control and Prevention. Good morning, Erin.
Morning, thank you. Hello, everyone. I'd also like to welcome and thank you all for this first session of our Antibiotic Stewardship in Nursing Homes webinar series. I'd also like to thank the Quality Care Health Foundation and the California Association of Health Facilities for partnering with us to develop and produce this series. All right, so I'm going to start this session this morning with a few brief remarks describing our program's role in promoting stewardship in nursing homes, and then the California legislative requirements for stewardship in healthcare facilities. And I'll then introduce the webinar series and our first session's presenter, Dr. Namali Stone of CDC's Division of Healthcare Quality Promotion. The Healthcare Associated Infections, or HAI program, is part of CDPH's Center for Healthcare Quality. So we're a non-regulatory program. We were created by mandate to oversee prevention, surveillance, and reporting of healthcare-associated infections occurring in California hospitals. The program produces an annual public report of these reported HAIs in order to support informed choices for consumers as well as to prompt providers to take action. We also provide consultation and assistance to local public health agencies to address infection prevention and outbreaks that occur in healthcare facilities. And perhaps most importantly to our mission, we engage in HAI prevention activities that include performing site visits and assessments in a range of healthcare settings, convening regional collaboratives, and then providing education. One of our highest prevention priorities is antimicrobial resistance, and this includes Clostridium difficile infections. During the past couple of years, we've seen hospital-onset CDIs in California hospitals, and so we focused substantial prevention efforts to address CDIs in hospitals. However, CDIs do occur across the continuum of care, and we know that transmission of the organism as well as exposures to antibiotics that predispose to CDIs also occur at points across the continuum of care. A recent population-based study estimated a substantial burden of more than 100,000 nursing home onset CDIs in the United States in 2012, and this translates to more than 14,000 CDIs among California nursing home residents. The opportunity for antibiotic stewardship as a prevention strategy for CDIs in this setting is evident in the fact that the great majority of these residents had received antibiotics during the prior 12 weeks. And the associated morbidity and mortality impacts of CDI for nursing home residents is evidenced by nearly 30% being hospitalized within 7 days and 8% dying within 30 days. So clearly, if we're going to mitigate the impact of CDI on Californians, we must focus some efforts in nursing homes. Another group of antimicrobial resistant pathogens include carbapenem-resistant enterobacteriaceae, or CRE, as well as other multi-drug resistant bacteria. These bacteria, fortunately, aren't as prevalent as C. diff, but because of their potential to spread and the substantial morbidity and mortality associated with infections caused by them, they're designated by CDC as urgent threats to public health, and our program is increasingly consulting on outbreaks of these organisms in skilled nursing facilities, particularly those providing subacute care. So another opportunity for addressing the role of antibiotic use plays as a driver of these resistant organisms across the continuum of care. Our program's core actions to address antimicrobial resistance include antibiotic stewardship as a key strategy to prevent colonization and infections with these antimicrobial resistant organisms in nursing homes as much as in other healthcare settings. Our program also supports efforts to improve infection control practices in healthcare facilities to prevent transmission. And so you might have heard about our participated in our prevention collaboratives that engage both hospitals and nursing homes in different parts of the state. We also aim to gauge progress and continuously refine the focus of our prevention efforts by tracking antimicrobial use and resistance trends. But today and throughout this series, we're of course focusing on stewardship. Antimicrobial stewardship can be broadly defined as coordinated efforts to promote and measure appropriate antibiotic use by optimizing selection, dosing, route, and duration of therapy. Now, particularly in the hospital setting, but increasingly in nursing home settings, stewardship has been shown to result in improved patient care, increasing infection cure rates, and reducing treatment failures. Reductions in CDIs as well as antimicrobial resistance have been observed, and these efforts have also been shown to decrease or control healthcare costs. California is really a leader in promoting and supporting stewardship through legislation. Since 2008, hospitals have been required to have a process for evaluating the judicious use of antibiotics. And then, since July of last year, so in 2015, hospitals have been more specifically required to have a stewardship program. So this is a policy in accordance with guidelines, a physician-supervised multidisciplinary committee supported by a physician or pharmacist who's had specific stewardship training, and then to report the program's activities to appropriate quality improvement committees. California is the first and remains, to our knowledge, the only state to have such requirements. And in the setting of these legislative requirements, really substantial numbers of California hospitals have been engaging in stewardship. So in a 2010-2011 survey of California acute care hospitals, about half of over 200 responding hospitals reporting already having an ASP, and then 30% reported planning one. And of over more than 100 hospitals that responded to the question, almost a quarter of them reported that Senate Bill 739 influenced their decision to initiate an ASP. In California, hospitals have been leading the nation in implementing stewardship. In a 2011 national survey of stewardship in acute care hospitals, California hospitals were significantly more likely to have stewardship policies in place compared with hospitals in other states. So then finally, to evaluate progress that's been made since the more recent hospital legislation went into effect in the state last year, our program is currently in the process of analyzing annual survey data that include questions regarding stewardship practices that hospitals are required to submit to us via the National Healthcare Safety Network. So California is again leading the way with a new legislative requirement for stewardship, and now this is in skilled nursing facilities. So California Senate Bill 361 requires by January of 2017 for each skilled nursing facility to adopt and implement an antimicrobial stewardship policy that is consistent with guidelines that are developed by CDC, CMS, or similar recognized professional organizations. And CDC has developed guidelines for antibiotic stewardship in nursing homes. The core elements that are shown here and available by following the link to their website on the slide. Now, you'll be hearing much more about these in the coming sessions, but essentially these core elements are aligned with those for stewardship in hospitals, and so we have leadership, commitment, and accountability to stewardship, antibiotic expertise, actions, tracking and reporting, and education elements. But these are all adapted to the nursing home setting, so acknowledging some of the unique considerations in this setting, including perhaps the role of consultant pharmacists, as well as other kind of frontline staff and families in guiding antibiotic use. More to come on those. But to support California skilled nursing providers preparing for this new mandate, the HAI program in our California Department of Public Health is partnering with CAF as well as CHF to offer this free 6-part webinar series. So there's each interactive 1-hour webinar is going to address a topic area that aligns with those Centers for Disease Control core elements of antibiotic stewardship in nursing homes. And we'll be featuring different presenters and panelists from key stakeholder organizations and practice experts, really, from around the state. Importantly, these webinars are really going to emphasize practical strategies, and we'll be sharing examples of implementation as well as tools. So here's the schedule and topics for the series, starting with today's webinar, really to provide the rationale as well as an overview of new requirements for stewardship in nursing homes and the CDC's core elements, as well as federal perspectives from Dr. Namali Stone from CDC, and I'll introduce her in a moment. We'll then move to engaging leadership support for nursing home stewardship, including some perspectives from a nursing home medical director, as well as a corporate nursing home organization viewpoint. We'll hear about strategies for engaging and partnering with the consultant pharmacy, including some perspectives from pharmacists with experience in the nursing home setting. and then move on to actions and intervention, including some practical examples, tools, and perspectives, followed by strategies for tracking use and outcomes, and finally reporting and education strategies. So now, without further ado, I'm so pleased to introduce Dr. Namali Stone as the speaker for our first session. Dr. Stone is the medical epidemiologist for long-term care in the Division of Healthcare Quality Promotion at CDC. She's a board-certified infectious disease physician who has a research and clinical background in managing infections and antibiotic-resistant pathogens in the elderly long-term care population. In her role at the CDC, Dr. Stone develops guidelines and educational resources and quality improvement programs to promote infection prevention and surveillance in the long-term care setting. And so thank you, Dr. Stone.
Thank you so much, Erin, for that very kind introduction and for the invitation to become a part of this exciting webinar series that you all are hosting there in California. It's really a privilege for me to have an opportunity to spend a few minutes with this audience talking about why antibiotic stewardship is such a high priority opportunity for nursing homes, and to start the discussion that you're going to continue over the next few months about how we can implement activities to improve antibiotic use in this setting. So as maybe I'll have one of my colleagues to advance the slide for me while I figure out how to get control. So we're going to touch on in the next few minutes some of the harms and issues with antibiotic use and misuse, and why stewardship is such an important priority for nursing home programs. And then look at what we know about current antibiotic use practice in nursing homes by reviewing a few studies and really trying to highlight our opportunities for improvement of our use. And then we'll look at the core elements again and see how those activities and those 7 foundational pieces really fit within your existing quality improvement infrastructure in medication safety. So on the next slide, let's look at the sort of call to action. Over the last few years, we've really identified improvements in antibiotic use as a key strategy for reducing antibiotic resistance and the threats from these bacterial organisms that are becoming more and more difficult to treat. And Dr. Epson alluded to a couple of the urgent healthcare threats that were identified in this 2013 antibiotic resistance threat report that CDC put out. And those were C. difficile infections and carbapenem-resistant Enterobacteriaceae. And for different reasons, these are urgent threats because of the importance of controlling these pathogens and reducing the burden of infections occurring in healthcare. A report that came about a year later from CDC described antibiotic use in acute care hospitals and really highlighted how much antibiotic exposure is occurring among patients receiving care in hospitals. So this report showed that on a single day, as high as 50% of people in a hospital may be receiving a course of systemic antibiotics. And when they dug a little deeper into some of the ways these drugs were being used, they found between 30 and 40% of those prescriptions may have opportunities for improvement in the way they were being used. So that definitely identified healthcare as a key setting and a key place where we need to be focusing our efforts to evaluate and improve the use of these drugs, especially since we know that the misuse of these drugs drives some of those urgent healthcare resistant threats. And about a year and a half later, the White House really made this a strategic national priority for not just healthcare, but also other areas where antibiotic use can be problematic, such as in agriculture and the way that these agents might be used in veterinary care as well. And they provided a strategic action plan for all these different partners and domains where antibiotics can be used and ways that we can focus on improving use as a strategy for reducing resistance. And that initial action plan included long-term care as a strategic healthcare setting where antibiotic stewardship should be employed. Let's go to the next slide, and we can see some of the other reasons why it's become such a public health priority. I think there's these three statements that, to me, sort of identify our opportunity in a nutshell. The first is recognizing that antibiotics can be misused in every healthcare setting, whether it's outpatient, acute care, as well as post-acute and long-term care. So it's across the continuum of care that we need to be doing this work. In addition, we've already heard of some examples of how antibiotic misuse adversely impacts our individual patients as well as larger public health of a community. And finally, I think we have an ample amount of evidence now showing that when we improve our use of these agents, we can really improve outcomes for our patients, as well as reducing the costs from things like resistance. And I want to, on the next slide, identify some of the common ways that antibiotics can be misused. So I'm going to have my colleagues sort of click through a few of these. So they can be given when they're not needed. And a good example of this is using an antibiotic to treat a viral infection. Sometimes we're continuing these agents even when they are no longer necessary. And I'll show you some data in a moment from a study in Canada that showed that despite a lot of guidelines that show shorter courses of antibiotics are just as effective, there are still providers that use long durations of therapy. When we look at drug selection and dosing, we find sometimes we're not adjusting for the underlying health of our patient, and especially in the older adult and long-term care population, we know that renal insufficiency can have a huge impact on how these drugs are metabolized. So if we're not careful about dosing appropriately, we can be overexposing individuals to these agents and causing higher risk of side effects. Sometimes initial drug selection may not be appropriate for the type of infection being treated, and this can occur when we empirically choose an agent and then find out, for example, that the organism is resistant to that agent. On the flip side, we sometimes use really big, broad-spectrum agents, even though susceptibility patterns of the bacteria that end up growing in culture show that there are narrower spectrum options available. And so when we overexpose to broad spectrum drugs, increased risk of resistance emerging and complications from those broad spectrum agents. And so these are just examples of how antibiotic misuse can occur, and it explains why we sometimes see studies describe very broad ranges in antibiotic misuse, because it depends on how we define misuse that allows us to quantify the problem. Going to the next slide, I wanted to look at some, again, of those harms that we see occurring when antibiotics are used or overused. Side effects in drug interactions are sometimes not considered as strongly when people are using antibiotics because often they are tolerated so well. But especially in older adults, we find a much higher risk of adverse drug events. And that can be because they are taking other medications that can interact with these agents, or as I mentioned before, there are changes in their metabolism of these drugs that are not accounted for when dosing. One large study estimated over 140,000 emergency department visits occurred in a year for adverse drug events related to antibiotics. Dr. Epson already talked about the role of antibiotic use and its connection to C. difficile infections, and we know that antibiotic use increases the risk of developing C. difficile infections as high as 7 to 10 times compared to people who are not taking these drugs. And in a given year, when you look across the whole country, we see almost 500,000 cases occurring of C. difficile. And then finally, again, this antibiotic use is the primary driver of antibiotic-resistant bacteria. And the 2013 threat report estimated that at least 2 million people are acquiring serious infections due to antibiotic-resistant bacteria in a single year. So now let's bring it down to a single case. And this is an actual case that was reviewed during an OIG report looking at harms in skilled nursing facilities. And so I just want to talk you through this example because I think it illustrates a lot of what we've been talking about. This was a 99-year-old who had a urinary catheter placed during a hospital stay because of urinary obstruction. And then they were transferred to a skilled facility in early July. And there was a recommendation for follow-up to manage the device a couple of weeks later in the outpatient urology clinic. Probably around the time that they should have been going to see if that device could be removed, despite being afebrile and no documented medical complaints in the record, there was a urine culture submitted and it was positive. And for those of you who work in long-term care, I don't think that this positive culture would surprise you, right? Because we often see that when residents have indwelling medical devices and urinary catheters, it's very easy for bacteria to adhere to that device and colonize the bladder. So the presence of many bacteria on that urine culture and the presence of white cells or pyuria on the urine analysis with that culture shouldn't surprise us because the device alone could account for that. But despite not having documented signs and symptoms of infection, they were started on fairly big gun antibiotics, Augmentin and Rocephin, or ceftriaxone. Now that was stopped probably as the culture susceptibility report came back from that positive culture. But then about a week later, you see the Augmentin broadened to a carbapenem. In this case, it was ertapenem, because a second culture result came back. And although I don't have it documented here, I think it's probably quite likely that that second culture showed an organism that was now quite a bit more resistant than the first organism they were treating. And again, there was no documentation in the medical record of any accompanying signs and symptoms to explain why these urine studies were sent. But the facility got to a point where they didn't know how to manage the antibiotics anymore because they had used the broadest agent they had available to them, and they were transferred back to the hospital as a result of this. So when the auditors were looking at this case, they felt that this was an experience of harm for this resident that resulted in them being transferred back to the hospital because the device had not been appropriately managed. But I would also say that this is an example of antibiotic misuse because there's no clear indication for these drugs being started and being changed, and it clearly resulted in a higher level of resistance affecting this individual. So that's just an example of how in the real world we can sometimes see this misuse occur. Going to the next slide, let's look at what we know about antibiotic use in nursing homes. There's a large and growing population of people coming into nursing homes every year to receive care. And more we're seeing that that residents are not coming from home or from the community, but they're coming directly from hospitals because they need skilled nursing care or wound care and rehabilitation. And the issue with this growing short stay post-acute population is that they're bringing a lot of the same risk factors that we used to see traditionally occurring in hospitals into the nursing home setting. And as a result of this more complex population, we're seeing a lot of antimicrobial use. In fact, antibiotics are among the most frequently prescribed agents in nursing homes. Now, on a given day, I had said earlier that the hospital population has an antibiotic use rate of about 50%. So 1 out of every 2 patients you might encounter is receiving a systemic antibiotic. In the nursing homes, if you had to guess, just think for a minute if you think that the number of residents on a given day receiving an antibiotic might be higher or lower than that 50%. And for those of you who work in this setting, you probably guessed it's lower, and that would be correct. In fact, it's more along the lines of 10 to 15% on a given day of residents who might be on a systemic antibiotic. And in comparison to the hospital rates, that doesn't seem very bad, right? But here's what we have to account for, because people stay in nursing homes for quite a bit longer than they stay in hospitals. You have to follow a cohort of residents over time to see the higher amounts of antibiotic exposure in this population. And that's where, again, I'll show you some data to support this, but that's where the higher proportion of exposure really happens. When you follow individuals over time, then you start to see that 50 to 70% of people will receive 1 or more courses of systemic antibiotics. And not unlike some of the studies that came out of the hospital environment, we also see in nursing homes a broad range of inappropriate use. And it depends, again, on how use is defined. That helps explain whether, why you see sometimes a fairly modest amount of inappropriate use on the 25 to 30% range versus the higher proportion of inappropriate use. So let me show you some of these studies. Next slide talks about how antibiotic use across nursing homes varies. So the graph on the top is looking at the distribution of courses of antibiotics started per 1,000 resident days across about 70 different nursing homes. And what I want you to see is just how broad the range is in use. Some homes use less than 1 course of antibiotics per 1,000 resident days. The median or average was about 5 courses per 1,000 resident days. And then you have on the way far end some facilities that are using over 20 courses per 1,000 resident days. So a very broad spectrum in how much these drugs are used in a particular home. The study also looked at some of the major indications for use. And again, those of you who are familiar and working in this setting probably aren't surprised that urinary tract infections and respiratory tract infections were the top 2 reasons why antibiotics were started. And in this particular study, we found that fluoroquinolones were the workhorse antibiotic, the most frequently prescribed, and accounted for almost 40% of all antibiotic prescriptions. And the fluoroquinolones, I think, are important to think about and look at how we use them, because there's a very strong connection between fluoroquinolone use and C. difficile infections. So if we're trying to protect our residents from the complications of antibiotic use, we have to think about the agents we're exposing them to. Now, this next slide shows a study that delved into the way antibiotics were used in the short stay or post-acute care population. So they focused in on just that subset of residents who were admitted to facilities to receive post-acute care. And there are about 220 admissions that they looked at across 7 facilities. Now, in this group, almost 50% of residents were receiving a course of antibiotics. And that mirrors that number of antibiotics used in hospitals, because this, again, right, is the hospital or recently hospitalized population. So I think it's important when we look at our buildings and think about how antibiotics are being used in our buildings, we recognize that the way they're used in the short stay population may look very different from the way we're using them in long stay. And when you calculated the rate of use in just the short stay population, you see it's almost 30 courses per 1,000 resident days, and that's 6 times as high as what we saw in that median amount of use in those 70 homes that we looked at just in the previous slide. Now, drilling down a little bit more into how antibiotics were initiated in this particular subset of residents, 50% of the time the antibiotics were initiated by the hospital. And for many of them, the indication was respiratory tract infections. Among the group that had the nursing home initiate the antibiotics, it was more often for urinary tract infections. So still, number 1 and 2 indications for use depended on where you started therapy to determine what the reason might be. Going to the next slide, I believe we are going to look at that data that was identified in the study for some of the challenges. So these first 2 bullets came out of that study I just reviewed with you. One of the things they identified was that 2/3 of the antibiotics ordered in the nursing home initiated antibiotic prescriptions were done over the phone, which to me is something we have to acknowledge about the way care is delivered in nursing homes. Most of the time our providers are not on site and they're relying on assessments being made by somebody else in the building. So the quality of information flow and the information provided during that decision definitely influences whether an antibiotic will be initiated. Another thing they found that definitely highlights an opportunity for improvement is that when they were doing chart review and trying to look at the nursing home initiated antibiotic courses, in over 40% they could not find the documentation of what infection was being treated and why these drugs were started. So very low-hanging fruit, I think, in terms of improvement. Other issues that we also have to be mindful of as we're looking at how we use these drugs and how we can improve them is understanding how access to diagnostic and laboratory testing is available for our providers. And that's not just for getting started and deciding whether to initiate therapy, but also when you come back and try to adjust or narrow therapy after more data comes back. And also a lot of providers worry about the influence of residents and family members and even other nursing home staff in the building in terms of driving antibiotic use, and their perceptions have a strong influence on decision making as well. Let's go to the next slide. And this is the Canadian data I was alluding to earlier. This is a really interesting study. They looked at all the residents who received long-term care in a large province in Ontario over an entire year. And there were about 70 to 75,000 people in Ontario who received care at some point in long-term care. And they found that 75% of those people, about 50,000 people, received 1 or more courses of antibiotics. So that goes back to that data of the longer you follow people, the more exposure you see. And when they drilled down a little bit to look at how antibiotics were being used, they found that 44% of the courses that people received exceeded 7 days in length. And they defined that as prolonged therapy because nowadays, you know, for many infections, especially common ones like urinary tract infections and pneumonia, the guidance says that 5 to 7 days is probably very adequate, more than enough to treat these common infections. So to get longer courses of therapy may indicate an opportunity to cut back on the duration of exposure. They tried to look at the types of factors that might explain why an individual resident received a longer course of therapy. And so they looked at whether they had more comorbidities, if they were more ill, if they had cognitive impairment. And the only factor that they found in a model that sort of accounted for all of these different factors, the only issue that could explain a resident getting a longer course of therapy was the provider who wrote the prescription. And I think it's a really important finding because it tells us that individual clinicians have beliefs about how these drugs should be used, and we have to understand those beliefs if we're going to help improve or rein in some of the way these drugs are prescribed. The investigators went on to look at the different providers that were prescribing antibiotics in this cohort. There were about 2,600 people, and they found that a fairly modest number, about 20% of the prescribers, were responsible for a lot of the antibiotic being given, almost 80%. So that 80-20 rule, and we hear it sometimes, 20% of people do 80% of the work. Here it's 20% of our clinicians are accounting for 80% of the drug being used. And they couldn't identify, again, any differences in the residents that these providers were caring for that could explain being a long duration prescriber versus a short duration prescriber. So they couldn't really prove that the residents that were getting longer courses, that were more antibiotic, were sicker. And I think that's an important message for our clinicians to be thinking about. This group in Ontario went on to describe in the next slide some of the harms that were occurring in nursing homes in Ontario that were considered higher consumption homes when it came to their antibiotic use. So they looked at the risk among residents for experiencing antibiotic-related harms based on the amount of antibiotic use occurring in the building where they were. And harms included side effects and adverse drug events, C. difficile infections, and becoming colonized or infected with a resistant organism. And what they found was that residents that resided in nursing homes that were considered high antibiotic use homes had a 24% increased risk of an antibiotic-related complication. I guess that doesn't surprise us. I mean, that kind of makes sense, but it's important to be able to have data like this to really highlight just how much more risk we may be placing our residents at based on how we're using these drugs in the building. So just to give you a sense of what the range was in how antibiotic use was defined, the low end of the range was about 20 antibiotic days per 1,000 resident days, but the high end of the range went as high as 193 days per 1,000 resident days, and they defined the high-use homes as any building that used more than 62 antibiotic days per 1,000 resident days. And another piece that came out of this study was that even residents not receiving antibiotics experienced some of those antibiotic-related harms in those high-use homes. Next slide, please. So we talked about some of the new proposed legislation and the new state rule in promoting antibiotic stewardship in nursing homes there in California. I think it's important to acknowledge that there are some other existing regulatory applications that already are in place for nursing homes that also promote stewardship. I've just highlighted a couple of the FTAGs that are relevant when we talk about improving antibiotic use. FTAG 441, or infection control, has language specifically around performing antibiotic review as part of your strategy for preventing the spread of antibiotic-resistant organisms. And then the next three tags are really all about safe medication use and improving the monitoring and prevention of adverse events related to medications. And while a lot of the time we focus our efforts on classes of agents like the antipsychotics and the opioids, where we recognize and think about the harms related to misuse of those drugs in this population, I would argue that there's a lot of compelling data now that antibiotics should also be considered a high-risk class of agents for which these medication safety regulations apply. But going to the next slide, I'll show you that there's some new proposed rules for nursing homes that CMS just made public in the summer of 2015. And if we can move to the next slide, please. That antibiotic stewardship became much more specifically identified as a new medication safety activity, which was integrated into both the pharmacy requirements and the infection prevention and control regulations that are being proposed for nursing homes. So this again was originally made public in the summer of 2015. These rules haven't been finalized yet, but here's some of the language that was proposed. The medication reviews being conducted by pharmacists should now specifically include antibiotics during monthly reviews, but also when new admissions and readmissions occur in the facility. There's some language asking for antibiotic use protocols and activities to monitor antibiotic use to become part of the infection prevention and control program. And these activities should be integrated into the quality assurance and performance improvement activities of the facility. Moving to the next slide. Dr. Epson mentioned that CDC released some guidance to nursing homes on how antibiotic stewardship activities can be implemented. And these 7 elements, as she mentioned, are the same core elements for stewardship in hospitals. And I would make the case that these are really the 7 foundational pieces that have to be in place for any quality improvement action that you want to put into place in your building. You have to have leadership commitment. There should be a champion or some individual or group of individuals identified to be responsible for the program and responsible for the quality improvement initiative. There has to be expertise. In this case, we talk about drug expertise in the way antibiotics are used and for the opportunities to improve their use. And those strategies for getting that kind of expertise might include working with your consultant pharmacists, partnering with antibiotic stewardship program leads at your referral community hospitals or referral hospital networks, because we know that a lot of our nursing homes don't have ready access to individuals who have been trained in infectious diseases or in the use of antibiotics immediately at hand. You have to start taking some policy or practice actions, and that is one of the foundational pieces of the Senate bill there in California, is identifying a policy. And then you have to track the outcomes of your efforts and provide feedback to your staff so they know that their changes at the bedside, their changes in their prescribing practices are translating to better outcomes and having the positive effect on the residents that they care for. And then providing education, not just to the facility staff, but I would say also to engage your residents and families, because they are also a key group that has perceptions and beliefs about how antibiotics should be used in this setting. So I want to pause there for a moment and just ask those of you who are on the webinar a quick polling question about where you may be right now in your efforts to put into place a policy or practice around antibiotic stewardship. So I think the poll is open, and I would encourage you to vote. Sometimes we don't realize that we have more in place. It's just that we haven't been calling something antibiotic stewardship, but it turns out that we do have a policy or a practice standard that would fit under a program to improve the use of these agents. So thank you for taking time to vote, and I think
Unmuted.
people have submitted their responses. I see about 60% of the folks have submitted a response. And about 2/3 of folks say that they do have a policy or have begun to develop a policy around stewardship in their facility. So I think that's very encouraging, and I fully believe that a lot of you do have pieces of appropriate antibiotic use policies and practices in place already, and it's just a matter of recognizing them and expanding some of that work. So that's very exciting to see. I'm going to just spend the last couple of minutes talking about education and highlighting for you some of the resources that we have available to start the conversation. If you haven't begun talking about antibiotic use, or you're looking for ways to initiate the conversation with your clinicians or your frontline nursing staff or your families and residents about why your facility is going to start paying closer attention to antibiotic use and identifying and improving opportunities to improve use. I think it's very hard to bring people on board with a new initiative if they don't understand why you're doing it. And these forums for having conversations with frontline providers and staff can be very useful in not only bringing them into the discussion and getting their support, but also help getting their input on ways that practices can be improved. A key part of education is understanding the barriers to changing antibiotic use practice, and I think we have to allow people to share what their concerns might be as we are asking them to shift their practice patterns. And this is another place where having data about your current antibiotic use patterns can be very powerful, because if you're able to show your frontline providers opportunities for improving how the prescriptions are being written, or you can show them that you, as a facility, are using quite a bit of a particular agent, that can help start a discussion about ways that can be adjusted or changed. And as you're bringing education to your residents and families, having tools available to your facility staff will make that conversation a lot easier. On the next slide, just wanted to acknowledge that there are a lot of informal leaders that may influence the way these drugs are used in your building, and having all of these folks at the table and getting their input and getting their perspectives can be really critical in making changes to the practice in your building. Sometimes we have senior staff or senior attendings that have been practicing in the facility for a long time, and they have a lot of respect, and they have and their opinions command a lot of attention. So those folks, even if they're not the named stewardship coordinators or leaders of your program, but their input is still really important in order to have successful improvements and changes in practice. So again, just being able to acknowledge and understand some of the barriers to changing can help you find the places where you'll be more effective. So the last few slides in this slide deck are just examples of resources that CDC has available, and as well as some other campaigns like the Choosing Wisely campaign. And they are all tools that you may be able to use to start discussions with your leadership, your staff, and your families and residents. So this is from our Get Smart campaign, and there's some documents about engaging families in discussions about antibiotic use. We have a lot of resources for clinicians on creating practice standards and looking at the algorithms for assessing residents when they're suspected of infection. So, that communication flow between your frontline staff and the offsite prescribers is effective and gets them the information they need to make good decisions. We have some specific resources for consumer education about what's important and what they need to know about how antibiotics are used and some of the harms that can be a complication of antibiotic use that they also need to be aware of. And that can start a conversation within your resident family council, or it could be used as a tool to talk about stewardship as people are newly coming into your building as part of the initial family meetings. It's usually easier to start the conversation before someone's in a situation where they may be needing an antibiotic or thinking that they need an antibiotic. This is material, also consumer education materials from the Choosing Wisely campaign, and there are statements from both the American Medical Directors Association and from the American Geriatric Society talking about improving the use of antibiotics for care of urinary tract infections in older adults. I think that's one of the first opportunities a lot of facilities come to when they think about where can I focus and improve my antibiotic use. And if you're really not sure where to start, there is a 2-page checklist that can help you walk through the 7 core elements of stewardship for nursing homes and help you start to see ideas for practices or activities that could be put into place, and also to capture practices and activities you may already have in place. And it sounds again like many of you have already got some things started that will take you quite a ways down the road of putting stewardship into place. So again, thanks so much for the opportunity to chat with you this afternoon, or I guess this morning for all of you on the West Coast. I think the opportunity for improving antibiotic use is high, not just in nursing homes, but across healthcare, and we really need to take action in order to protect our residents from the harms that can occur when these drugs are overused or misused. There are a lot of current as well as some future regulations that are setting expectations to start looking at our policies and practices and monitoring of antibiotic use. And I think as you're getting started, it's really important to go slow. Try to find 1 or 2 activities that you could start with to put into place and measure the impact of those changes so you can provide that feedback and encourage your staff to continue moving down the road. So thank you again. It's exciting to see this discussion happening there in California and across the country. I look forward to hearing how your webinar series continues to progress.
Great, thanks, Molly. So when just looking at questions, there was really one, and it was more directed. Did you see it, Erin?
Yes, I see that there is a question asking if there's going to be a webinar or seminar that is actually, directly for physicians about antibiotic stewardship. And, I guess I'd say that really, any and all of the webinar sessions that are part of this series, I think would be pertinent for physicians. So, Deborah, can you bring up the slide with the schedule of the remaining series topics? And, so I think any and all of these, would be relevant in that, I think physicians have a role in all of these sort of activities in terms of, garnering their leadership support and, some of the partnering with consultant pharmacy or other ways to engage, getting expertise for nursing home stewardship. I think I'd say that maybe the one topic where there's more sort of direct physician involvement would be in some of those actions and interventions. So the September 29th session, but really I think any of them would be pertinent. So we'd encourage physicians to join all of the sessions that they can.
Great. There are a couple other questions. Do you see them, Erin? Do you want me to read them?
I can see them. Let's see.
So the next one, is there an ASP P&P template?
Yes, okay. I can sort of see them, but they're really kind of tiny and I have to scroll through.
I know.
on the screen here. So yes, so not currently. Dr. Stone showed the checklist that that the core elements document contains, and so we could certainly provide links in follow-up to this webinar to that particular checklist on the CDC's website. I guess what I would say is turn it back to the participants and such. If there are folks out there who know of some examples of templates that they think would be worth sharing, please feel free to share with me, and I can kind of disseminate them. We are going to be collecting these as part of sort of a repository of tools that we'll share on our CDPH HJI program website. So please let me know if anyone has something already developed or that they would like to share or is aware of a tool out there.
So the next question is, how do you feel about prophylactic use of antibiotics prior to dental work?
How do I feel about it? Well, there are published guidelines, and I'm not sure if Dr. Stone would like to also weigh in on this one. With regards to specific indications for antibiotic use prior to dental work, and I think that those indications are a bit more sort of restrictive than what is kind of common practice. I would refer to those guidelines. I believe IDSA has those on their website. I don't know if you have anything you'd like to add, Namali.
Yeah, I think I think you're absolutely right. There are clearly specific indications where antibiotics should be given as part of prevention of bacteremia and endocarditis. But in many clinical practices, we see those guidelines are extrapolated well beyond how they should be applied. So if you have, if you do have those kinds of dental services made available in your facilities, that might be an area to look at and to see if there's opportunity for educating your colleagues who are providing those services to make sure that they are appropriately using these drugs but not overusing them.
Great. The next one, what role do local hospitals with existing ASPs have with regard to ASP support for nursing homes? Is there any existing data on this?
So there are examples of community groups where a hospital has identified an opportunity to do outreach with their referral network of nursing homes and start to talk about antibiotic use at the care transition and to provide some support for improving or helping the nursing home program start to evaluate their antibiotic use. I don't know that, I know of some specific groups in California, and Erin, you may be highlighting some of that work later in the series, where they've started to get some experience with the relationship between hospital stewardship programs and nursing home programs. There's not, to my knowledge, any regulatory expectations yet that would drive that interaction, and the way partnerships are developing, they may not always be sort of financially driven, but for some hospitals, they've just recognized that if they can reduce the complications from antibiotic use in their referral network, things like C. difficile or resistant organisms, they have improvements in their efforts locally to reduce those complications, and they're seeing a reduction in readmissions because there's not as many infections manifesting in post-acute care and coming back to the hospital. So a lot of these programs have developed as a result of alignment between nursing home and hospital priorities to reduce readmissions, and I think opportunities to learn from them.
Great. There are several more questions that have come in. We're really out of time, and we want to be respectful of our presenters today and their time, and then also of all of our attendees. Like I said, I will pass these on to the presenters, and we will have a page on the QUAF linking from the Antimicrobial Stewardship webinar to questions and answers. Does that work for you, Erin and Namali?
Certainly.
I can forward
Absolutely.
to you. Great. And then there was one question I can answer real quick. Is registration required for each session of the series? Yes, it is. They will be posted probably about a month ahead of time. We are working on the May 18th program right now, so probably within the next couple of weeks it will be available on the website to sign up for. Like I said, this is all the time we have now for the webinar. You may obtain your CE hours by filling out an evaluation that will be emailed to you after this webinar. On behalf of Namali, Erin, as well as QUAF, CAP, and the CDPH, thank you for joining us and taking your time to view this presentation. Have a great day. Thanks.
Thank you.